The topic is hypertrophic cardiomyopathy. The myocardium is hypertrophied, and as compared to the free wall of the ventricles, the septum is markedly hypertrophied. It's the most common inherited heart defect, strong genetics involved. It's inherited in an autosomal dominant pattern, and it's got variable penetrance. There is mutation in the genes involved in contraction of the muscles, and such as in beta myosin heavy chain most commonly, and also in troponin T and tropomyosin genes. This may be obstructive or non-obstructive, and ventricular relaxation is impaired, and so is the filling. The septum is involved, and because of the thickening of the interventricular septum, blood ejection is impaired. The outflow tract being obstructed, and the ventricular volumes are small, and there is an increase in ejection fraction. Many folks live with this condition, and they never develop any symptoms or obstruction. In young athletes, this is one of the causes of sudden death, and most people also go on to develop heart failures and dilated cardiomyopathies. Patients often complain of syncope, dyspnea, palpitations, and of course sudden death can occur. There's a systolic murmur. It's kind of harsh, and it can be heard at the left sternal border or the apex, and it's like crescendo, decrescendo kind of murmur, diamond shaped. There's an increase in murmur with the Valsalva maneuver, and with squatting the murmur is decreased in intensity. S4 is there, then there is paradoxical splitting of S2, especially if there is an obstruction to the left ventricle, and there is a bispurious carotid pulse, and a forceful double or triple apical impulse. The outflow obstruction worsens where there is an increase in contractility or decrease in ventricular volume. Situations such as tachycardia or Valsalva maneuver, hypovolemia, standing positions, drugs such as the beta-adrenergic stimulators such as dopamine, epinephrine, isoproterenol, then the nitroglycerin vasodilators, diuretics, or alcohol. They all tend to increase the obstruction. And squatting, hand grip exercises, bradycardia, volume expansion, beta-adrenergic blockers, calcium channel blockers, alpha-adrenergic stimulators, or diisopyramide, they tend to decrease the obstruction. During systole, there's a gradient that's basically established at the contact point where the anterior leaflet of the mitral valve comes in contact with the septa. Chest X-ray would show cardiomegaly. Echo is very handy for the diagnosis purposes, and what you would see is basically increased ejection fraction. The ventricles would be hypertrophied, and of course the ratio of the septum thickness and the thickness of the free wall of the ventricles would be also much higher. MRI also kind of helps to look at the hypertrophied um, segments. ECG would also show the ventricular hypertrophy signs, and some Q wave abnormalities can be appreciated. In echo, one can appreciate the outflow obstruction along with the systolic anterior motion of the mitral valve. Treatment-wise, one needs to decrease the inotropy and the heart rates and treat any hypertension. Now, try to avoid positive inotropic drugs and digoxin. Utilization of beta blockers of verapamil to slow the heart rate and decrease inotropy and treat hypertension is often there, and use of verapamil should be done cautiously, especially in folks with high resting gradients and severe symptoms. Propranolol is used, and verapamil basically helps decrease the outflow obstruction and by improving filling, and also reduces myocardial ischemia. Diisopyramide is useful as an antiarrhythmic because it's also got a negative inotropic effect, and therefore reducing further the outflow gradient. And utilization of digitalis, diuretics, nitrates, vasodilators, it should be avoided, and one should avoid dehydration and any strenuous exercises. For folks who go on to develop dilated cardiomyopathy, they need to be treated just like systolic heart failure, and it's important to screen family for HCM, and avoid any atrial fibrillations. Treatment has to be done for arrhythmias, as mentioned before. Arrhythmias are also seen with this condition. ICDs are utilized in special situations, especially with a history of syncope or extreme hypertrophy and other high-risk situations. Dual chamber pacing and excision of the septum, partial excision, and catheter ablations, and then mitral valve replacements. All are utilized in special situations.